So let me welcome you again, since I'm just starting to record, and brought to you by Smart Dog Productions. Today we're talking about congestive heart failure and breaking the cycle of congestive heart failure. And so to break that cycle is very important because of readmissions and being docked by Medicare for readmissions. And so it's costly to have readmissions. So we're going to talk about left bundle branch block. This is a little cartoon of the left and right ventricles and of the heart with a sort of a section that may be sort of coronal. And we see here the right atrium, and we see the left atrium. We see the SA node. We see the AV node, the bundle of His, the only way to get down unless there's an accessory pathway. And then we got the left bundle divides into anterior and posterior fascicles, the anterior being skinny and the posterior being fat. So you can usually get anterior hemiblock rather than posterior hemiblock, and then the right bundle, which comes down this way. And so you can see that we have some EKGs over on the left-hand side, and one EKG, there's probably V1, these are probably V1, and you've got the RSR prime, which is the rabbit ears that you frequently see with right bundle branch block, and you can see it's symbolizing that this little rabbit ear represents the left ventricle depolarizing, and then this little rabbit ear is the right ventricle depolarizing, and so it's left first and then right, which this is a depolarization of the septum that you can see that occurs in that direction, and so that'll make that happen. And so then if you come over here, the left bundle, we got the right ventricle depolarizing first, and then the left ventricle, and that's wrong, and it's not supposed to work that way, and that creates the left bundle branch block, and the left bundle branch block is leading to that, so it's one begets the other, so to speak. And so that's what happens, and we're going to talk more about that, and how to recognize the left bundle is by looking at these two particular patterns. And so here's our nurse navigator and scheduler saying, call CHF busters, and say, who are you going to call? And we're talking about left bundle branch block today, and here's our basically CHF busters here. They're coming into the fore to prevent congestive heart failure. So we want to know everything we can about congestive heart failure so we can understand how to keep it from happening and how to prevent a recurrence. And so here we've got 21,000 patients where they're trying to prevent recurrent readmission from congestive heart failure to the hospital with at 70 sites, private practice and academic, with a great deal of effort and scrutiny over 2009 and 2012. And during that period of time with 21,000 patients, they were able to get the readmission rate down for a grand, looks like 1%, 1%, from 20.02% to 19.05%, whoop-de-doo. And so no statistical difference. And so a fail. So even though you say, well, I'm a great doctor, I can do that, all I have to do is pay attention to the salt, keep them off the potato chips, and make sure that they weigh every day, and take their blood pressure, and see them in the clinic often, and have my nurse call them, we can prevent their readmission. Well, wrong. You've got to do something dramatic to prevent readmission. You've got to come up with an idea. You got to be thinking. This is a cognitive thing. It's not following a recipe of guidelines. It's a cognitive thing. You got to be thinking about what's wrong with this patient. Why is this patient here in the first place? And what do we need to know? What don't we know? And how can we find out more? And so let's see what that might be. And here we go. Well, we have an office-based congestive heart failure clinical practice. We have our own management system that we've added to what we call next generation cardiology. And so we've got a PA who's very much involved in data gathering and liaison with our patients with congestive heart failure. So that's a first step. And then just by happenstance, we have one of the 6 cardiac trained transplant cardiologists in Tampa, and so that's me. And so that makes for a good quarterback who's had some experience and understands who goes to LVAD, which is some of the very few patients, and who has to have a transplant. Again, very few patients. And then who's garden variety congestive heart failure and what can we do for grandma? And then access to best cardiac imaging. Well, we sure got that. We got cardiac PET, MRI, CT, 4D echo, echo strain. We've got it all linked by computer. And so I can look at those images anytime I want from anywhere in the hospital or the clinic. And so we've got tremendous probably resources for imaging the heart and knowing how to apply each one to each individual patient, because I'm not an MRI doctor, I'm not a CT doctor, I'm not an echo doctor, I'm not a PET doctor. I have facility in each one of them, and that's the way we train our fellows, to be able to know what's the best test today on this particular patient. And then you've got to have access to highly skilled, high-volume EP doctors. You've got to have an EP doctor that really has a vast repertoire of information that's above and beyond what most cardiac physiologists would understand. So it's going to be a very complex knowledge of left ventricular, left atrium, right ventricular, right atrium physiology. An interventionalist. Well, we need a world-class interventionalist. We need somebody who can do CTOs on a regular basis, because CTOs, which are chronic total occlusions, are very important to us, because sometimes the CTO, if you open it up, you can reperfuse a great deal of myocardium because of functional myocardial mass that's inhibited from working because it's not getting enough blood and not getting enough oxygen. Sometimes we can open that up and make the heart a lot better and no more congestive heart failure. And then a structural heart person, which is meaning something to do with the valves that can be fixed. And so that's transvenous, transpercutaneous aortic valve replacement, or apical aortic valve replacement, or mitral valve replacement percutaneously, or mitral clipping with the mitral clip. And then cardiac surgeons who are very adept and very good at doing the high-risk patient. And so, and then frequently we will encounter these doctors with a webinar, and we'll get together with them and show them what we're doing and show them some pictures and go online together with the patient looking at the images. And that's particularly useful. And we do that all the time, especially when the doctor we're working with is remote, say somebody in Houston or somebody at Emory in Atlanta, and so, or someone in New York and NYU. And so we have people that we work with in all those places, and they'll just log in and look at the images with us, with the patient here, and we'll have a great discussion. Just like in the old days when the cardiac surgeon, the cardiologist were not too busy to together meet with the patient and the family. So that's a good thing. So let's go on to our next image here, and let me open up one of the microphones and open up another microphone and send a invitation to someone. So as we develop this management system, we seem to be getting more and more connected electronically. And so, well, here's a connection electronically. This is with something that's an EKG or an ECG. It's an app on your phone. It's called a LiveCore or a Live ECG. Many of our patients who have arrhythmias will purchase one of these at Amazon for about $75. They put the attachment on their iPhone, put their fingers on the plate, and be able to transmit EKGs to me, to my email address. And I can just look them up. And I get several EKGs a day. Sometimes maybe too many a day. But I get them to look at them and help patients that way. And so that's very easy to stay connected. And then we have pacer connections now, where the patient has a home pacer unit right by their bedside, and they connect it up, and it goes by phone to email, and my PA can get online and take a look and see what's coming in today. And then we can talk from the car while you're driving. You know, hopefully you've got Bluetooth, and so you can be in touch at any time. That's not my car, but it would be nice to have that car. And then you can have an ER robot, which we have a teleneurology robot in the ER, and that's easy to adapt to telecardiology because in the drawer, locked in the drawer, is a stethoscope, and you can transmit the EKG, the echo, and the heart sounds with the robot. So we've got a lot of our hospitals are connected with these robots that are used for teleneurology, maybe once or twice a day. So there's a downtime of maybe 23 hours, and so we can use that on the downtime for cardiology and easily get connectivity. And then hopefully at some time we will get, something called CardioMEMS, which is not available right now because of the pricing. But I've got this sort of blank spot here for plugging in CardioMEMS. So we'll be able to get the PA pressure sent to us from the patient's heart by a sort of a pillow into our system by email, and we'll be able to contact that. And then the nurse navigators have their iPhones and they have contact. And then there's actually ways of plugging in phones that have specially protected HIPAA compliant telemetry so that we can talk to people and share images without worrying about HIPAA. And there's a system called Vidyo, V-I-D-Y-O, that offers that system from going from the phone to going to massive amounts of telemetry data every day to a tech who might be, or a nurse who might be sitting in front of 7 monitors, monitoring 7 patients 1,000 miles away, and looking at their images, looking at their catheter information, EKGs, respiratory, and a database of vital signs, and talking to them and looking at their picture. And so we have all kinds of complex, interrelated tele-data that's becoming more and more available every day. And so, well, we can see mortality decrease from medications. And this is good to keep in mind that an ARB will give you 15%, an ACE will give you 18%. Ivabradine, over a period of 23 months, gave an additional 18%. Well, I can use every little percentage. You know, this is even, isn't, you know, 15% is massive over a large number of patients. 18%, look at this. Mineralocorticoid receptor antagonist like spironolactone, here's 28%. Beta blocker, I get 35%, so that's a big one, usually Corag. And then here's our new drug, Entresto, where that's topping a lot of them with 38%. There's Bidel that's topping a lot with 43% with certain ethnic groups. So we can add these numbers up and see how much we can get. Looks pretty good to me. And so we're going to talk about pacers if we're going to talk about left bundle. And so talking about pacers is pretty important because a lot of patients we see with congestive heart failure have BiV pacers. A lot of them have ICDs, and those are intracardiac defibrillators. And so let's look at all the kinds of pacer functions that we can have on individual patients and need to evaluate and understand. And so we've got someone who has a backup pacer that was put in as sort of a fail-safe. It's like an insurance policy. It's like if you have a systole for a couple seconds, maybe 2-second pause or 3-second pause or more, and you're symptomatic, you can have this put in as an insurance policy or a backup. Well, unfortunately, frequently when they put it in and set at a rate of 60, because you set a rate of 60, it'll run down sooner, and then you can sell another one. So it gets set at 60 when it gets put in, and so you got to say, well, do I really need this pacer to take over all the time and run down its battery? I don't think so. And so you might say, well, what I'm worried about is asystole, you know, a pause of 3 seconds. So why don't I just set this pacer at 45? It'll never go off unless somebody has asystole, and I'll save the battery, and I'll have years more of use on it. And you know what? You know that probably the most important thing is that someone functions electrically as physiologically as possible. So as physiologically as possible is SA node, comes down to the AV node, comes down to the bundle His, comes through the left bundle, right bundle. That's physiologic, and it turns out that that's the best method of actually I guess that's the best method of depolarization that's possible because it results in sequential AV activation, and it results in activation of left ventricle then right ventricle, and so you get everything just perfect in terms of delivering a stroke volume. And the stroke volume times the heart rate equals the cardiac output. So we can get new symptoms of congestive heart failure if this isn't working, or low cardiac output if this isn't working. So if we have a new pacer put in, and it's a right ventricular pacer, and we start right ventricular pacing the patient because of a syncopal episode when his heart rate dropped to 30, and we start pacing him at 60 or so, and that's the way he's pacing, that's not going to be physiologic because we're going to be activating the right ventricular apex first, then the left ventricular septum, and way over to the lateral wall last, and that's asynchronous, and that's not going to work very well, and you're not going to maintain the same stroke volume, and that's going to be a kind of pacer syndrome. And so you might even get retrograde tricuspid valve or aortic valve opening, tricuspid valve or mitral valve opening, and get some TR or MR. And so all kinds of crazy things can happen when you're doing that, and it's not physiologic and it's not needed. So you got to shut that down to only when it's needed, which means it's on standby and it's an insurance policy. Now we can get atrial pacing, right ventricular pacing. We can get, which is not exactly physiologic either, because where we pace the atrium is not going to be near the sinus node. It's usually in the right atrial appendage. And so in the right atrial appendage, that's not going to be physiologic. That's not very close to the sinus node, but it's a good anchor spot. So the right atrium is going to be squeezing funny. And so we got atrial pacing, biventricular pacing. Well, that's getting closer to being physiologic. But in terms of biventricular pacing, again, we've got an RV pacer at the apex, and that's not where the RV normally depolarizes. It depolarizes at the septum. And then we've got a left ventricular pacer lead that's gone somewhere. Sometimes it's in a vein that goes down by the diagonal vessel, sometimes in the posterior lateral vein where it belongs, but that's still not physiologic because it's not coming down the septum like normal. So that's the substitution for physiologic for somebody who can't maintain the physiologic type depolarization of the SA node, AV node, His bundle, and the ventricles, both left bundle and right bundle. And so you have to always remember that when we're using a pacer, we're doing something that's not physiologic, and reverting to normal conduction is always the best, and preserving that as best we can. AV dissociation doesn't work out very well because you don't get the atrial kick, and so the atrium is contracting. Sometimes when the tricuspid and mitral valves are closed, not a good idea because you're not getting that little extra burst of stroke volume that's increased by the atrial contraction. Ventricular asynergy is when both ventricles aren't actually working at the same time, and so one's contracting when one's relaxing. Atrial asynergy, when the atria aren't beating together. Atrial atony, when the atrium has been so scarred or so damaged that it's not contracting at all. Ventricular pacing causing mitral regurgitation, which we'll talk about, and ventricular pacing that makes mitral regurgitation go away, which we'll talk about. And the only way you're going to find out this is to turn the pacer on and the pacer off and see what happens to the MR with an echocardiogram. So there's lots of little tricks we can learn of how to test out how the pacer is doing. Unfortunately, everyone's living in a different silo, and this big silo of congestive heart failure has a lot of doctors involved, and then there's interventionalists over here in this little silo who have the capability of opening up an occluded vessel that may be a chronic total occlusion that goes to a papillary muscle that's causing papillary muscle dysfunction, and could be a very great help in congestive heart failure, but they're over here and we're over there. And then the EP doctors, who are fewer and far between, who are over here in their silo and they see the patient, set the pacer, and then they come back and see you, and you say, why is the pacer set this way, and what happened? And oh, I went to my pacer clinic. And so then you've got to optimize the pacer all over again with an echo and with the pacer rep there to help you manipulate the pacer settings. And so unfortunately, we don't get together. And so it's nice if you know a lot about EP. It's nice if you know a lot about interventional. And so let's move on. We're going to talk about the case of the grandmother coin collector. And so this is a really nice lady that was probably one of the first ARNPs in the history of the world. And so she's in her 80s now, and she's a coin collector. And I had no idea until I had a grandchild born, and she brought me a silver coin that's actually, it's from the mint. It's never been in circulation. And it's a beautiful, beautiful silver coin made out of silver, specially sewed to her. And the price has already gone up since she gave it to me. And it was such a nice thought and such a nice present. Apparently she gives these to all of her grandchildren, and my daughter fit the bill for her, and that was so sweet of her. So she said, and so I said, I collect coins. And she said, what? Yeah, I've got coins from my childhood that I collected. And she said, well, bring all your coins in. And she actually called to remind me on Friday when she had an appointment on Monday. And so I had to bring all my coins in, drag them out from the closet, and put them out there. And we went through every one of them. And she'd say, oh, that's a good one. And she'd say, oh, this is all silver. Well, this one she thinks is the most beautiful coin ever. And when it's silver and gleaming, this is walking liberty. And so she's got sitting liberty, walking liberty. It was very interesting. You can learn so much from your patients if you're tuned into them and if you got time to talk to them. So let's look at Betty. And she's 83 years old, one of the first ARNPs. She was admitted to Memorial Hospital in 3/25/13 with her first episode of the rapid onset of congestive heart failure that's frequently called flash pulmonary edema. She said she walked out to her car. All of a sudden, she got very short of breath. She couldn't move. She couldn't do anything. And she said, thank goodness that she was in sight of the road, because her neighbors could see her, and her neighbors came over and called 911, and she wound up in the hospital. Well, NT-proBNP of 8,974 is a pretty high one for a lady who's 83 years old. She's a thin body habitus, female. All those combinations make for, you know, what you would say a higher NT-proBNP because it's metabolized by fat. And so this is higher, but it's much higher, and this is an astronomical NT-proBNP, and we can't subtract because of age. We can't say, well, it's because of female thin body habits makes higher ones. This is certainly outside the ballpark. And the patient has progressed in terms of her EKG, which we always look at for damage, from left anterior fascicular block to then developed a rate-related left bundle branch block where it was related to phase 4 depolarization, which meant that when she had a slow heart rate, she then had left bundle branch block. And then later that progressed to permanent left bundle branch block. And we see we've got milliseconds here because the duration of the conduction of the left bundle is very important when it comes to how the ventricle depolarizes itself and whether there's assynergy between the right and left ventricles and how dramatic the assynergy is. So we've got a left bundle branch block with 132 milliseconds, not very long, and at slow rates she had left bundle, and then finally she had permanent left bundle, and it was always there. So look what's happened to her. We come congestive heart failure admission, bail her out. Here she comes 11 days later, back in the hospital. This time 4,564 was her NT-proBNP. And then out of the hospital again. Everybody's doing the best they can for this lady. Very surprised she had congestive heart failure. Back in the hospital in 37 days. Wow, you know. So we started wondering about what's going on. She's got some chronic kidney disease. Her creatinine's 1.48. She's got the left bundle. Should she have a V pacer? Does she meet the Medicare criteria? Well, she did have an echo, and it looked like she was having diastolic dysfunction, not systolic dysfunction. And so it's very perplexing why this lady wound up suddenly in the hospital within 3 months, 3 times, and with BNPs to demonstrate that she's definitely having congestive heart failure, not COPD, and that she's got some kidney disease as well. So let's see what we could find out about her. And then a year later, she comes in with acute pulmonary embolus. She has some hospitalizations for other reasons, but we're going to focus on the congestive heart failure and what's going on. So worsening congestive heart failure is a terrible thing. It's a terrible thing if you're a patient because you can't breathe and you're starving for oxygen. It's a terrible thing as your left ventricular dysfunction becomes greater and your heart is sort of going on a downhill slalom, as you can see, vertically coming horizontally, almost vertical drop coming downhill. With each acute event, the troponin goes up and you lose a little bit more muscle, and you might say you're circling the drain. And so this is not a good thing, and we need to do something to stop this cycle. So this is breaking the cycle of congestive heart failure. And so let's look. Heart failure was associated with high hospitalization and readmission rates. Very high. Look, 25% all-cause readmission within 30 days and 50% within 6 months. Wow, that's a lot of readmission rate, and that's a very dangerous thing. Each time the patient is wondering if she's going to get there in time to be rescued, and if she's going to get enough oxygen in the ambulance, and if she's going to have the relief she needs. Right now you're getting IV Lasix in the ambulance. You might be getting some morphine in the ambulance, certainly high oxygen flow, and some change in posture in the ambulance, all the things that we can do to try to make her better before she gets in the emergency room. Heart failure hospitalizations are a strong predictor of mortality, especially with the troponin positive. Each admission means we're losing more muscle. And so each admission decreases the patient's chance of survival. So we got to figure out how to break the cycle in each individual patient, and that means we got to have some original thoughts. And so you're not going to follow a guideline. You're not going to say, well, you had too many potato chips. I think you had too many cans of Campbell's chicken and rice soup, because look on the can. And so the first thing to do is to blame the patient. And so blame the patient makes it easy. You don't have to think. You don't have to bother soul searching or trying to figure out what's really wrong with the patient, looking at some kind of image. You just blame the patient. Well, it turns out that recent data shows that people who are salt restricted with congestive heart failure don't live as long, and that if you have a more liberal salt diet, they do better. So we're wrong about that. It's not some salt thing. And of course, if we look at those CardioMEMS recorders, recording the pulmonary artery pressure and transmitting it, you will find that you can predict the hospitalization for congestive heart failure 30 days before it happens. 30 days before you can detect volume changes, pedal edema, increased shortness of breath. 30 days before you can see the pulmonary artery pressure is drifting up, and that wasn't from eating a bag of potato chips the day before admission. And so we're all wrong about that. And I've seen that happen so many times, and you can't do that. That's not a cognitive approach to the problem we're addressing. So let's see what her medical problems are in addition to, because it's a gestalt. As cardiologists, we are internists. We're trained in internal medicine to start with. So we've got to understand each patient is all of this coming together at one time. So, well, she's got MRSA colonization. She's an ARNP. She fears having surgery because she says, I've got MRSA. I don't want to have surgery. And so she's right about that. She could die, get infected, and die easily. She's got GERD. She's got a large hiatal hernia. She recognizes that symptom. She's got COPD, and it's mostly asthma. She never smoked in her life. We're going to look at her and say, oh, she's a pink puffer, cigarette smoking. Let's blame the patient again. Let's beat up on her a little bit. She's never smoked in her life. You're attacking the wrong person. Hypothyroidism, hey, probably perchlorate in the San Joaquin Valley contaminating our lettuce has caused an epidemic of hypothyroidism. And no one knows, the EPA won't come up with guidelines as to how much perchlorate is okay, because we'd have to shut down the entire San Joaquin Valley growing area if we come up with certain numbers that would be essential and meaningful. So we can't do anything about that. Hypertension, you know, a disease of aging. You get to be 90 years old, you're going to have a 90% chance of having hypertension. 80 years old, 80% chance. So it increases with aging. Renal dysfunction, very common with hypertension. Creatinine of 1.48. Well, we got to think of that because we're going to be diuresing this patient. Vocal cord dysfunction, that's a rare diagnosis. What does that mean? Somebody's hoarse? No, it actually means that you start getting short of breath because you're closing your vocal cords and you can't breathe. And the only way you can diagnose that is with an ENT doctor who's basically sort of witnessing an attack and saying, is this what it's like? And yeah, and then looks at the vocal cords. And so it's a very rare diagnosis nobody ever considers. I was pretty proud to make this diagnosis of the lady because here she is having these episodes of shortness of breath, and she can counter that with behavior changes. And so I felt pretty good about that. That was my coup of the year, vocal cord dysfunction. And then sleep apnea, well, that causes a lot of problems at night. If you do blood pressure monitoring 24 hours, which you got to know how to do in your office, because if you don't do it, you're going to miss the whole story of hypertension. You've got to be able to find out what happens with sleep apnea. She had a colectomy for CA and survived that. Gastric retention is another problem. So she's got a lot of problems. And so, but that's not as bad as many of our patients. I've got a lot of people that have a list of 50 problems easily, and are still walkie-talkie and doing really well with 50 problems, a 50-problem list. And so let's see what happened with cardiac imaging. Well, I'm a cardiac imaging guy, so let's see if these cardiac images helped us and what kind of guidance I can get from this. And so, well, cardiac cath in 2001, minimal 30% right coronary artery disease. Well, who hasn't had a cardiac cath? You know, the patient's circulating through here. You know, most of them had at least 1 or 2 caths. You show up in the ER with chest pain, you get a cath. So that's no surprise. And so serial echocardiograms. Well, that's easy to do in the office. And actually, we have a better echo machine than they do in the hospital. And actually, our transthoracic echo is equal to the hospital's transesophageal echo in terms of the detail, because the echo machines have changed so much in the last 5 years. And if you haven't replaced it in 5 years, then you're not going to have pretty pictures. So it's better to see the echo over here than it is over at the hospital. In most of the hospitals I've visited, it seems like they just can't keep up with the echo technology or don't want to. And so here we got an ejection fraction of 58% with abnormal septal motion, secondary to left bundle branch block. Okay, well that's interesting and important, because left bundle branch block causes the septum to be activated at a different time, and the lateral wall takes forever to get over to the lateral wall in terms of depolarization. So we can actually go back to our first picture. Let's go back to this one. There we go. And so, okay, if we're used to going down this way, and there's supposed to be an anterior and a posterior fascicle, you know, we would get over to here in a little wall as we go down this direction. We might come across this wall. We might come across this wall. This is just a cross section, and so it can easily extend out across walls and get over here to the lateral wall. Lateral wall may be last, but if you're depolarizing with a pacer from the apex, or if you're depolarizing normally down your right bundle, it's going to take a while longer to get over to the lateral wall. So the septum is going to be depolarized much sooner than the lateral wall. Septum is usually depolarized from left to right. Now it's going to be depolarized from right to left, and then this is going to come over the lateral wall. So by the time this is repolarizing, this is depolarizing, and so it's going to be out of sync. So it's not hard to see that dyssynergy or asynergy is going to be a problem. Let's go back to where we were and see what happened to her ejection fraction, because we're worried about this dyssynergy leading to left ventricular dysfunction in the future. So here we are, we're asking the question, you know, in 10 years, did she get coronary disease? And here's our ejection fraction. I don't know how we got 36%. We may have been having some PVCs or something. But finally, with dobutamine atropine, we got a really good squeeze of 82%. This was before she had the left bundle being a prominent problem. Before that, 2011. And so then in 2000, and then she had a 3-vessel coronary calcification on the CT for attenuation correction of the PET scan. And then when she, of course, we wouldn't use atropine dobutamine if she had a left bundle, because that basically makes the septum become even more ischemic because it's because of the change in contractility. And so there's normally decreased perfusion of the septum with left bundle branch block. And if you increase the right, it'll be more decreased, and we'll get an artifact in the septum that's very common. That'll be decreased perfusion for sure, but it won't be from a coronary artery disease. And so no perfusion defects. And now we switch to persantin, so that means the left bundle is there. And so when you have a left bundle, we don't use dobutamine, makes the heart rate go too fast. We want the least increase in heart rate, and persantin gives you a 5 beat per minute increase in heart rate over normal. Lexiscan will give you a 21 increase in heartbeat over normal, and it could, of course, with dobutamine atropine, we're going for the target, which is 85% of max for age. And so, so we had a normal study, and that was good. So now we're in 2014, and we're not doing PET scanning currently because of the price of the generator, and you have to have, you know, maybe 75 patients to justify a generator. We're going to do MRI because we can do that every day without ordering an isotope that's very expensive. And so now we've got an ejection fraction. Well, MRI is the gold standard. So the ejection fraction is 38% with normal perfusion. But then when we do the late gadolinium enhancement, we find new scar that's not complete left ventricle. It's incomplete thickness. It's about 50% thickness of the left ventricle, involving septum, anterior wall, inferior lateral wall, and inferior wall, which makes you think, well, what causes scar in the subendocardium? That's got to be an infarct. And so unless you have LVH and you get scars, it's usually coronary artery disease. You have to have severe LVH to get scars without coronary artery disease. And so it looks like she's had some silent infarcts, gotten some damage to her heart. It doesn't look like it involves the lateral wall where we might be putting the pacer if we put a pacer wire in for her left bundle, but it looks like she's had deterioration in her LV function from her left bundle, giving her a synergy. So can we help Betty? What can we do for her? And that brings up the possibility of a pacer. So here we go. She's going to have a pacer put in. She's going to have an RV lead. But that's not going to solve the problem. You're still going to have left bundle branch block if you put an RV lead in. So you got to have an LV lead. Unfortunately, they couldn't get that in, but they did get a bundle of His lead, which is going to make physiological contractility. So that's a good thing. If you can do that, it's maybe better than the LV lead. And, you know, the LV lead is not really in the LV. It's actually a lead that goes in the coronary sinus and is threaded out into the branches of the coronary sinus, and you're trying to get it in a posterior lateral branch. Well, if you're going to put in a posterior lateral branch, you got to make sure there's no infarct there, because you can't pace an infarct. So we got to put it into, you could use the MRI for guidance. As a matter of fact, you can actually superimpose it on your fluoroscopy screen and make sure that you put that in superior lateral position so it won't be pacing a scar, because it's not going to work. And so now we've got a couple leads, one that's going to be outside the left ventricle, but in the bundle His type area. We're going to have a right atrial lead. I guess that's inside. That was inside as opposed to inside the right side up into the bundle His rather than the coronary sinus. And then an ICD, and then we did an echo post-pacer, and we've got improvement in function. So let me show you our echo post-pacer, and we had no more struggle to control fluid problems. So no more admissions, and so we solved the problem. Well, that's really great. We thought diastolic function was the main problem from the beginning, and we talked to her about putting a pacer in a BiV for left bundle with diastolic dysfunction. Well, that's not Medicare guidelines, but Dr. Herwig and I believe that that actually improves patient diastolic function as well as systolic function, and that that's useful in patients who have left bundle and diastolic dysfunction and recurrent congestive heart failure. But we'll have to save those patients and write them up. So let's see if I can show you that echo. Hang on for a minute. Okay, so now you can see our echocardiogram up on the screen, and I'm looking at it, and I see the posterior basilar, sort of lateral wall, mitral valve, left atrium, left ventricle. This looks like a pacer artifact in the right side. There's the pacer lead that's sort of exaggerated and fuzzy. That's the pacer lead in the right ventricle. And it looks like there is pretty close to synergy. It looks like they're coming together systolically at the same time. So that's what we wanted to accomplish. So that looks very good. Let me see some more pictures. Now we can clearly see the pacer lead. There's the pacer lead in the right ventricle. There's another one that's pacing the His. I'm not sure exactly how we see that, but there it is. And there's the left ventricle, and it does look synergistic. Not exactly beating entirely normally, but it does look like the walls are coming together in a timely fashion. So you see some TR. There's always TR where the pacer lead crosses the tricuspid valve. It's not normal to have a tricuspid valve with a pacer lead going across it. And so obviously it's not going to coapt exactly right, and there's always going to be TR in various amounts, sometimes severe, sometimes actually a leaflet will fibrose and become adherent to the pacer lead. And so frequently tricuspid regurgitation, this is minimal compared with what we see frequently after a pacer has been in for a long time. So we saw that there was no significant mitral regurgitation and there was no mitral stenosis. And now again we see the ventricle looks pretty decent in terms, it's not normal, it's dilated, it's not beating entirely normally, but it's good enough. It's good enough to keep her out of the hospital since that particular time. She hasn't been hospitalized for congestive heart failure since then. So we broke the cycle. We were successful. Let me get back to the ODE screen. Hang on. Let's talk about some of the other causes of congestive heart failure. So in terms of that, we have a lot of little old ladies who get congestive heart failure, and they're very delicate. And so Gloria was one who basically had readmissions for a congestive heart failure every month, and she had a BiV pacer in for left bundle branch block. She would get left bundle branch block when she was going very slow. She would get left bundle branch block when she was going fast. But there was a sweet spot in between where she would have left anterior fascicular block. The posterior fascicle would conduct. And so she would not have left bundle branch block. In that sweet spot, she wouldn't get congestive heart failure. So if the pacer took over, congestive heart failure. If her left bundle became prevalent, congestive heart failure. But if I could keep her heart rate in this zone of about 68, 72, she wouldn't have congestive heart failure. So we said, okay, we've got to slow it down so it doesn't go fast. We've got to set the pacer so it won't come in. And we've got to get her heart rate just right. And so to get it just right, she was on digoxin, she was on several drugs, and we did. We succeeded in keeping her heart rate in this 70 zone, and the pacer turned off until she got really, really slow. And so we did pretty well, and we kept her out of the hospital for 16 months, which was a record for her. And then she developed an atrial tachycardia. We sent her to, and this is the problem, you got to really communicate with your EP guy. And I called the EP guy, but he was very busy, and we talked about her, and I wanted him to ablate the atrial tachycardia. But when he got her there, he ablated the AV node. And by ablating the AV node, that solved the problem with the atrial tachycardia, but it made it so it totally did away with the sweet spot. So we lost the sweet spot, so she started going back in the hospital every month, and she basically died of congestive heart failure. And that's communication is so important, and I thought I got the message across, but I didn't. And with the ablation of the AV node, we lost the sweet spot, which we probably would have lost sometime anyway. But we certainly found that there was a very narrow margin to keep this lady with LV function that was adequate for her existence. The diastolic dysfunction group, that's a tough group in terms of medications, in terms of therapy. They seem to do well with the cardiomems because it looks like that's one big group we can influence by predicting they're going to have congestive heart failure by looking at their PA pressure 30 days before the event and making adjustments. So that may be certainly an option. How about pacer if left bundle and diastolic dysfunction? Dr. Hurwitz and I are collecting cases. That may be an option. Pacer-induced mitral regurgitation, pacer-resolved mitral regurgitation. When I first saw pacer-induced mitral regurgitation, I really didn't understand it, and I turned the pacer off, it would go away, I turned it back on, and what happened? So I called Dr. Stromquist, who was putting pacers in at the time at Tampa General, and he said it doesn't exist. And I turn it on, and there it is, and I turn it off, and I can't believe it doesn't exist because I have to believe my own eyes. So then he goes and asks Dr. Mester, and Dr. Mester said, no, it doesn't exist, you know? And so I turn it off and turn it on, there it is. And so I collected about 3 or 4 cases, gave them to somebody else, and he wrote them up. And the next time I talked to Dr. Stromquist, he said, yeah, there was an article about him. I read this article, it does exist. So it doesn't exist if it's not written up and in the literature. So that's kind of interesting. And then pacing too much. There are patients that we have that are pacing that should have their normal conduction, and we should turn the pacer down till they have normal conduction. And so that's an adjustment that we have to make. We have to make and so I see those all the time where they're pacing too much, and all we have to do is turn the pacer down to where it's not pacing at all, but it's on standby in case of emergency, in case you get a very slow heart rate, and then you have normal conduction, you have your normal pacing, and you're fine. So pacing too much, congestive heart failure, very common. Some other funny things to congestive heart failure: renal branch artery stenosis, flash pulmonary edema, the lady across the street from me. I get tired of getting up at 3 in the morning and rescuing her, and so we found this and fixed it, and she didn't have congestive heart failure ever again. Paroxysmal atrial fibrillation can cause a problem, especially with LVH or HOCM. Got to get rid of the atrial fib. You can tell for sure when they go in atrial fib that that's what's going on. Complete heart block with congestive heart failure happened to my mother-in-law. I went and picked her up and brought her in, and we took care of her. Heart rate was 36, but she had normal LV function. How did I know that? Well, you know, I did an echo at her home because I took an echo with me. I took an EKG machine. I took a bunch of drugs. I took a couple bottles of oxygen and went over there and I came into the ER and I had the EKG, I had the echo, I had the pulse oximetry, and the ER doctor wanted to know where the lab work was. We got little old guys who have papillary muscle dysfunction. This seems to be pretty common in little old guys. We've gotten some little old ladies too, but more common in little old guys for some reason, and that has to be usually the first diagonal vessel, the ramus or the OM1, have stenosis or CTOs. Sometimes it adjusts itself and resolves spontaneously. Other times we got to go in with, we have a patient that Mr. DF, who basically has told that nothing could be done, and when nothing could be done by his doctor, who didn't do CTOs. It wasn't nothing could be done. It was nothing could be done by his doctor. He didn't do chronic total occlusions. So we found what was wrong. It was an OM1. We got Dr. Stromquist to open it up, and the guy has been fine for the last 6 years, where he had to sleep sitting up because of congestive heart failure. And so sarcoid, amyloid, we do everything we can, but we reach a point where we can't do any more. Profound bradycardia, second to PVCs, and all I have to do is ablate the PVC. So if your heart rate is 50, but every other beat's a PVC, and that PVC is not opening the aortic valve, then your effective heart rate is going to be 25. So you don't do well with a heart rate of 25. Heart rate of an elephant's 36, a whale's 36. Person, is more like 60 or 70, so 25 won't do it. But if you ablate the PVCs, then you won't have the pause, and you'll have a heart rate of 60 again. So we have various patients that we've done that on. Sometimes LV dysfunction secondary to ventricular ectopy. That's another group that we have. And again, if you ablate the ectopic focus, you won't have LV dysfunction, complete heart block, aortic stenosis, aortic valve. So we have another patient to talk about very briefly. It looks like we just about the end of the time, but I want to tell you that his QRS duration increased very subtly 2011, 2012, 2013, 2016 to 150 milliseconds, and he got a pacer put in for having a slow heart rate at night, asleep, with digoxin and metoprolol on board to control his AF with RVR, because he had permanent AF and he had permanent left bundle, but his left bundle wasn't bothering him until it reached a critical phase of having a millisecond duration QRS of 150 milliseconds. And so that's when the left bundle became even more progressive and it became a problem. And he had asynergy. We were able to demonstrate that his current pacer wasn't doing the trick because it's an RV pacer. So here he is, 8 months after having a pacer put in, and we got to upgrade his pacer. He's got to have basically not the old pacer, 8 months old, but he has to have a BiV, doesn't need an ICD, so we should be able to do that. His ejection fraction has dropped from 50-something% over here to 26% over here, and his cardiac output, he's got a leaky mitral valve, a leaky tricuspid valve, and so 50% of the volume was probably going backwards, but we don't have enough to go forwards, and we need ejection fraction of at least 50 or 60% to be able to do that. So he's going to get a new pacer. So that's our story today. Thank you very much. Cardiac congestive failure busters. We hope to see you again next week. Actually, we're going to skip 2 weeks because I'll be lecturing out of town when I get back. So we'll be skipping 2 weeks, and I'll see you then in October. Thank you. Bye-bye.
Thank you, Doctor.
Thank you.
Thank you.